Welcome to It's Your Move. This program is a project of Westchester Independent Living Center, or WILC. We are a disability rights advocacy information referral center located at 10 County Center Road in White Plains. I'm Lisa Tarracone. My guest tonight is Jeff Zitofsky. He's my co-worker at WILC, and his title is Mental Health Specialist and Peer Independent Living Advocate. Jeff and I are going to talk about redefining mental illness and how the concept of the recovery model has dismantled conventional treatment for depression and other forms of mental health issues. Jeff will also discuss his role as a facilitator and trainer, where he works to challenge conventional belief systems that stigmatize and label individuals with disabilities, which can create barriers to self-actualization and empowerment. Welcome, Jeff.
Thank you.
Hopefully your conversation will be a little more fluid than my opening just there. So, okay, all right, that's good.
Okay.
Great. So, Jeff, I'd like to start with the overall definition of recovery as a grassroots peer movement, which I think had its start in the 1980s. During that time, consumers of the mental health system, we like to call them consumers and not clients, began to call themselves survivors of the oppressive practice of institutionalization, psychotropic drug treatments, and electroshock therapy. This is like a dark legacy, right? During the 1950s and 60s, folks were sterilized at times, they were lobotomized, they were locked up, solitary confinement, and oftentimes were never let out. So if you could speak a little bit, tell us a little bit more about the recovery movement and how that came about.
Well, it's even as far, like, long time ago, women were actually big proponents who wanted to just volunteer and help out, and once they saw this situation of psych hospitals, they're just like, what's going on here? So that was long before 1950.
And why women, I'm wondering? I mean.
Well, because they were the helpers.
Okay, the nurses.
The nurses, the helpers,
right,
the teachers,
okay.
the people who cared.
Right.
And so just closing those down.
Right.
And as of late, they're starting to close more and more, but it's still a slow process.
Right.
So it was just about how we are treated by our communities. That people are difficult to deal with, so we'll give them a medication,
right,
so they can not make us uncomfortable.
Right.
We can give them in a hospital so we don't have to see them and be around them.
Right.
So it's also about the treatment of people when they're in hospitals and shut away from our communities.
And also, it's a peer movement, though, right? It's folks with mental health issues, and is that the correct term? Survivors of the mental health system, and there's a lot of different ways you can refer to somebody who has experiences mental health issues.
Yes.
Disorder, I don't like to use that word, it's kind of negative, but mental health issues or mental health disabilities, I suppose.
Okay.
But it's the peers themselves, right? It's the folks themselves that kind of rose up and resisted, right, the oppression of that institutionalization at that time, and what was the practices at that time.
Yes.
And they formed their own movement. So you mentioned the women sort of maybe bringing attention to it, but weren't the folks themselves, right? I mean, they were didn't they come together and form like the Consumersurvivor movement, which then segued into recovery? Yes,
and I would say most consumers, I only like to use the word consumer if someone has a choice.
Okay.
All right, and that's what I do feel. Most of us, when I use the word consumer, it's like you have a choice. You can use my service, you can use other services, that you have a choice.
Consumer of services, in other words.
Consumer of services,
right, yeah.
Because when I first heard consumer, for me, it was just like I'm this Pac-Man who was just like eating services on SSDI.
Yeah,
so to nowadays to say consumers have a choice, and I think people rose up to say, I don't want to take a medication.
Right.
I don't want to have electroshock therapy. I don't want to be hospitalized. I don't want to be taken by police if something is going on. So yeah, the one that comes to mind that I know the most is Howie the Harp in New York City. Yeah. And now there's, a program named after him within Community Access.
Sure.
And I have
Give a little information on Howie the Harp for folks who don't know.
Well, it's actually started as a training program for people with mental health in the system receiving services to be able to work in the system and give that point of view to deliver services. Now, there are many of us who feel that we shouldn't deliver services other people do. So we're the peer in the group. We're less than.
Right.
So we're fighting to be equals. And the word peer means equal.
Right.
If you look it up in the dictionary, it means to look curiously,
Right,
and also
exactly.
to mean equal. So that's how I treat the word peer.
So let's talk about that a little bit. I know I was going to talk about that a little bit later in the show, but let's talk about it now since you raised it. So you work as a peer advocate, right, at Wilk? And we're an independent living center.
Yes.
So how is our approach different than, say, a provider agency? And define provider agency, please.
Provider agency provides services. A lot of times it's clinical services,
Okay.
housing services, case management. We at Independent Living Center, which I love, I've only been there a few months now.
And we love you.
Oh, thank you. So what I loved about it, first and foremost, is it wasn't told to me right off the bat. It's just like, as I work there, things unfold. And one of my favorite things there is that we don't ask for what's called a psychosocial, which
Explain
means
that.
it's something that needs to be signed by your doctor saying what your disability is, and it's pretty much your psychological history. We don't ask for that.
Right.
And all the other agencies, whether they're peer programs within it, we still had to have that. And so people would sit around a room and discuss people's charts without knowing the person, even before they enter it. We don't do that at Wilk. I just love it. Yes, we ask for people what their disability is, because in order to deliver what we do for the funding, they need to have a disability. But we take their word for it, which should be enough.
Right.
Which is what I love. So that in and of itself, the way we approach mental health, and that is very refreshing, and I like that.
Right.
People come in and we're people first.
Yeah, and we're a peer-controlled or member-controlled agency, right? So our center is our board of directors are over 50% folks with disabilities, various types, and staff as well. And we're the experts, right? Nothing about us without us, right? So we're the experts on our own, our own care and advocacy. You mentioned just a few moments ago that peers they're not like real experts, or they're not authority figures. That we're just a peer, but that is obviously you just mentioned at Wilk. That's different, right? Peers are driving the process.
Yes.
We're working with other peers. We're creating more advocacy and grassroots momentum around the issues that matter to us.
I mean, what are we trained in?
Right.
We take trainings, which is interesting, but I'm not trained in counseling. Or how does one become a case manager? It's just you learn skills as you go along to deliver services. And what I like about what's happening at Wilk is I'm learning about laws and advocacy and helping people with accommodations.
Right.
It's all very interesting to me that I'm learning, but I'm using as a peer, as Jeff, my life experience. So when someone comes in and I say, I have experience similar to yours, do you want to hear about it? It creates a connection.
Absolutely.
And then that connection helps empower us both to move on and create things in our lives. And that's what we as peers, if you even want to use that word, can do to create a relationship so we both can move on. And now I think independent living, to be independent.
Yeah, exactly.
In our communities,
right.
not outside them.
So you mentioned as a peer, you have your own experience. If you'd like to share that with us.
Yeah. Well, we talked earlier about medications and electroshock therapy. Medications weren't working for me, and I was on pretty much, when people name medications, I had tried it. So they asked if I wanted electroshock therapy, and I said yes. If I knew now what I knew then, I wouldn't.
Right. Did they explain to you what electroshock therapy is?
They did. That being said, they said that it would only be a little bit of memory loss that I'd get it back. And they weren't listening to me when I was saying I don't remember chunks of my life that have nothing to do with what I was going through. And I still am missing chunks of memory. Family and friends say that it helped me, and I believe them. But for me and what I've lost, of the sense of self that I've lost and the memories, I would not do it again.
Do you feel you gained anything from it? I mean, you said family members felt it helped. Did you feel it helped with your symptoms, whatever symptoms you were experiencing, depression perhaps?
That's hard for me to say, just because that's a pro and con list.
Right.
Yeah. That's hard. That's hard for me to say.
Sure.
But it is part of my story, and I get to share it.
Right.
With people who may be thinking about it, who have gone through it. So everything that happens to me and happened to me is I get paid to share it and live it, and to say this is my story. I'm not going to shame myself for it or let other people shame me, but it's the part of connecting people with it.
So you mentioned earlier about what you like about Wilk in terms that we don't ask folks for their
psychosocials.
Psychosocials. And you did a workshop at Wilk recently, a few months back, perhaps, on disability pride. Sorry I missed that one, Jeff, but
That's
I
okay.
read all about it. And folks that went there really, found it extremely informative. And so the discussion in part you had was who decides what disability is, and do we even need this label? And I want to invoke someone right now, Mary Ellen Copeland, who is a healthcare educator and founder of mentalhealthrecovery.com. And I interviewed her years ago.
Oh, wow.
Yeah, I did a story, a 3-part series on depression. She was amazing. And one of her quotes, she says, she had electroshock therapy. She was on all kinds of toxic psychotropic drugs, lithium. She lost vast portions of her life, her memory. It wasn't working for her. It was toxic. She was living a fraction of the life she felt she could live. And she felt that she was deferring to authority figures that knew more than she did, right? She's just a peer, right? So she said, but first you need a vision of hope, one that rejects the notion that you were a victim of your illness. And once she was able to do that, she was able to actually get off all these drugs and live a very full life and use complementary modalities, meditation, aromatherapy, all kinds of things, relaxation techniques, and she's not taking anything on, living a very full life. So is this what you mean about the dangers of labels? When someone labels you, it's what Mary Ellen did here was to reject the notion of a label.
Yeah.
Was that what your Disability Pride workshop was about?
Yeah, it's labeling, and it's just models, and
Yeah.
models are created to help understand what's going on.
Mm-hmm.
And the medical model that she was living under, that
Right.
I lived under for so long, was this is how we understand it, so we're going to treat you based on what we understand.
Right. Yeah.
So I don't hold it against them, because there's still people that I
Yeah.
know who use the medical model. It's helpful for them. And I even need to advocate for them, which is
Right.
what Wilk teaches
Sure.
me to do as well. And I like that, actually,
Yeah.
to put my stuff aside. But the model, doing the disability pride thing and the research that I did, is learning about the social model of disability. Is like, if we had, in instance, the people in wheelchairs, if there was access everywhere and all the counters were the same height, would you be disabled if you had access to everything?
That's
no.
a discussion we've always had, right? If the environment was more, then it would, right.
Yes.
It's the environment that disables you, right?
Right, so the
It-
whole notion of disabled that's based on what society is not giving to people in
Right.
order to succeed.
Right.
So that whole label of disability is like, and then to have pride in it as well. What we found out through that process is that pride comes from what we want to feel prideful about. And if I am labeled with a disability and they call me that and I want to have pride in it, I'm going to have pride in it. So it's just disability pride turned out to be is what is pride, why do we feel pride about ourselves and our stories, not to shame ourselves.
Right.
And for the movement to say this is the language that people use right now is disability. I tried to use as much as possible differently abled.
Okay.
A lot of people trip up on that
Yeah, sure.
and have to ask questions,
Yeah.
which is not a bad thing.
Right.
But disability is what people use right now.
I mean, so for me, I use the word because it's just easier sometimes when I describe myself or I'm
Sure.
filling out a form. But I'm disabled. I'm very able, okay? I'm not dis anything. So yeah, I mean, words mean a lot, labels mean a lot. And, and attitudinal judgments, right? Stigma is huge. I mean, so we've got barriers in the community, but then we've got attitudinal barriers, which are huge. And I think when it comes to mental health issues, I think that's probably one of the greatest barriers. I know there's a lot of, in the public discourse right now, there's a lot of discussion around, gun violence and fear. And I think that we saw that up front and center around Kendras Law, right? So Kendras Law, for those who don't know, Andrew Goldstein was an individual who pushed Kendra Webdell onto train tracks in New York City in the, I don't know, what was that, early mid-'80s perhaps? Not sure now. And he was somebody that was not taking his medication. He was, so during the 70s, the 80s, I think, and early 90s, all these state institutions, they were closing, right? The recovery movement we mentioned earlier, large institutions were closing, the advent of antidepressant medication, people were given the choice to live in the communities as it should be. And some folks chose maybe not to take medication. He perhaps was not on medication, or maybe he was fearful of going for medication, which is also happens. and being maybe locked up again or institutionalized,
Sure.
and he had such a fear of his memory of institutionalization that perhaps he didn't. We don't know. But for whatever reason, he pushed Kendra Webdell onto the tracks and killed her. And I think it was the fastest, the legislation was so fast-tracked because everyone got on board. Mental illness, fear, and they created Kendras Law. And I think that was an example of public fear driving a process that could really harm and embolden stigma, right?
Yeah.
And so Kendras Law, if you want to explain that briefly, what that law is.
Well, honestly, Lisa, because I've been consistent with my being a survivor of the movement, I haven't really focused on the laws
Okay.
and what's going on. When I taught it in the training
Yeah.
at the beginning,
Right.
I did it, but then my training moved to focus on creating relationships, is what we as peers
Right.
first and foremost are supposed to do. So honestly, I could sit here and pretend that I know
That's
a lot
fine.
about it, but I'm sorry, I
No,
really
that's
don't,
okay. I mean,
because-
I think Kendras Law, according to, Harvey Rosenthal, who's the president of NIAPRIS, the New York State Association on Psychiatric Services,
Rehabilitation, yeah.
rehabilitation. It allows for forced treatment because of what happened to Kendra Webdell, and this man, Andrew Goldstein, was not taking his medication, that it would be easier now to force somebody into involuntary treatment. So it also ramped up, and the whole discussion then of violence and mental health, and that quieted down for a while, and now it's sort of back with all the gun violence we have, and linking mental illness with violence,
Sure.
right? And then there's stigma that drives that.
Well, most people don't know that actually people who are labeled with mental illness are more likely to be victims
Correct.
of any
Yes.
type of violence
Right.
than perpetrate it.
So, I mean, the FBI Behavioral Science Unit quotes that the majority of crimes are committed by people with all levels of functioning, and only 3% are due to mental illness. And they're oftentimes, as you mentioned, right, the victims
Right.
of crime. But, and you mentioned, we talked briefly before the show about the two sides of gun violence, right? Or the right to own guns if you have a mental health issue.
Yeah.
And also, the confusion around that. Because there's fear of people with mental illness as being violent, then that also infringes on their right to own a gun, correct?
Yes, and then it becomes, for those of us who want to feel safe, but then it becomes an equal rights issue.
Right.
To say, wait a second, if in fact only 3%, why are you stigmatizing and saying
Right.
it's really to help the public feel more safe for us to be the scapegoats
Yeah.
of this? And, I say that we all have pain. And so as a mental health specialist and as a advocate, I don't focus on the diagnosis and what we go through in that. I just focus on the pain that I've had in my life and relate that to people. It doesn't even have to be labeled as trauma. But people go through difficult things, and then it could be argued to say that people are just not diagnosed with things. Just because they're diagnosed with things doesn't mean they're not going to go out and get a gun and perpetrate, murder and violence. It's people have a spectrum of pain, and we all can relate to that. And as a peer, that's the type of work that I want to focus on, and the joy.
Right.
It's called the clinician's illusion of we see people when they're at their worst coming for services,
Right.
no matter what. Oh, you're in pain, so I'm going to do this. But we don't see people as whole people.
No.
And at Westchester Independent Living Center, we also focus on groups, and not even groups, but programs that get people in the community to feel joy.
Absolutely.
And not so focused on what we don't have.
Absolutely. You and I talked about triggers. We have a few minutes left.
Yeah.
So the triggers of symptoms. I know that somebody has an issue, a phobia, or some type of episode or a symptom. It could be described as a mental health symptom.
Sure.
And you could say, well, this person's never had anything happen to them. Why? What's the reason for this? And you mentioned, we did have an interesting discussion about past life regeneration, or there could be traumas that you hold from before you were born, perhaps, right?
Okay.
And there's a lot of, I think there's studies that have been done into this, that have been done around this. And you can come into this life with certain predispositions. And then you can be triggered throughout your life, right? Into experiencing some type of pain that may manifest in a mental health issue.
Right.
And you talked about past life regression as a sort of treatment. Is that something that you ever participated in, or that you know anything about that you could talk about? Or?
I'm such a cynic.
Oh, okay.
Even though I love learning about that stuff and practicing it sometimes, there's still a part of me that's just like, why?
Okay.
Why is it working? What I've come to the conclusion for me in talking with people is, if it helps you and you're not causing harm and it's not causing harm, what is wrong? Kermit the Frog is actually my mantra. He says somebody thought of that and someone believed it.
Yeah.
And look what it's done so far. That's in the Rainbow Connection, a children's song. But I really do feel that we all have imaginations. We all have ideas. Try it out. And if it works for you, more power to us. So with past life regression, there is a lot of studies on it and friends that I know who really, really believe in it. I believe in other alternative methods, but we all have imaginations. Use them.
So give us an example of some other alternative methods that have been helpful for you and to others that you work with.
Focusing on joy at all costs.
So how do you do that? When you're in the throes of depression or in the throes of darkness, how do you focus on joy?
Well, I've stopped using depression because depression's not a feeling. I focus on what's happening versus what's wrong. And so I can say to me, I'm feeling anger right now. And as an actor, using improv, is like, where does anger manifest itself in my body? So the first thing I do is focus. You could call it meditation, mindfulness if you want to. For me, it's just like, okay, I can feel stress in my shoulders right now. I'm going to relax it and see where that leads me. And that comes from a place of joy and wanting to feel good and joy. And so all those things, just for me, focusing on joy, meditation. I used to run a meditation group at a place where I used to work, and people think you have to close your eyes and own. I said, let's just look at each other. Let's just focus on our breathing and
be
look.
Present.
Absolutely,
Yeah.
be present. And so in the throes of darkness, when I even hear throes of darkness, that connotes that it's going to last a long time. It doesn't need to for me all the time. That doesn't mean I can't sit with somebody who feels that way and relate.
So for you, if you can answer this, or you'd like to answer this,
Sure.
You mentioned you went through electroconvulsive, and various
I'm
types,
smiling about it
various
now.
types of drugs, right?
Yeah.
How did you move away from those forms of treatment? What was it for you? Was there a catalyst? Was it a gradual moving away? Was there some epiphany? I mean, how did it work for you?
Side effects, which I think they should call effects. They're not side anything. Those are more harmful for me than
Their
the
whole body manifestations, right?
Yeah, and so when people kept saying, Jeff, your liver, you have to watch your lithium levels, you have to get tested for this, I'm like, what is this doing to my body?
Right.
And so as I kept advocating for myself to say, I don't want this anymore, and even I had a psychiatrist said, you're going to be on this medication for the rest of your life. Well, I got cured from an ear infection. Why can I get cured from mental illness, which might have even been an illness in the first place?
Sure.
So it's a change in thinking and getting support, being around others who feel that way too, and also letting go of anger about it and focusing on the positive.
Some may say that's kind of like akin to the placebo effect.
Sure.
Okay. So I knew for myself with a physical disability, I was told certain things too, certain outcomes that would happen to me. In my disability, I'm 35 years now as a wheelchair user, and none of it has happened because I rejected it. I just rejected it like 5 or 6 years in.
Wow.
And I think that this is what Mary Ellen Copeland says, right? Once you believe, first you need a vision of hope, and that you reject those notions. So that's really interesting. I know I speak to folks. I had mentioned talking to a few folks I was having on the show today, and people who are using certain types of psychotropic drugs, they'd like to be off them, but they've been told that they need to be on them the rest of their lives, right? And maybe that's not the case, you're saying. That there's a possibility that may not be the case.
If they need and want to say that, I support them in that.
Right.
Because there was a time in my life that I felt that way too. By the way, I love the fact that you describe yourself as a wheelchair user. That's being in the moment to me.
Yeah.
Then I could have said, I'm a lithium user. I mean, I'm not bipolar or a personality disorder. I'm a lithium user.
Right.
But then So I love the fact that that's very present in there, that you're a wheelchair user. And if you could go more places with your wheelchair.
That's what helped me. That was my story of getting
Love
out and self-empowerment, which is again what our agency's about, right? Empowering ourselves, using ourselves as models, and disseminating that information to the people we work with, our peers. Jeff, we've got like 2 minutes left.
Okay.
Any closing thoughts you'd like to leave our viewers with? And I also would like you to leave your contact information as well for folks to call you if they have questions.
Okay. Let's see if I remember our telephone number right off the bat right now.
I'll help you if you don't.
Thank you.
I don't know your extension though, so.
914-682-3926.
Very good.
Wow, muscle memory. That's our main number. My extension is 2123.
Okay.
My email is jzitofsky@wilk.org. We have a website with different things on it, which is great. I would just like to say, as a mental health advocate, it's just health. And we're whole people. And I just want to relate to people and share and help them understand that even though they're coming to me for services, I will deliver them to them. But what happens if they know that they're helping me at the same time?
And I'm sure that happens. And you let them know that, right?
That's
an exchange.
That is the exchange. I think science keeps telling us that over and over. And what if we're transparent about that, to say, you coming in here is important for not only you, but for me and us as well, and how that changes things.
So they
People
feel they're
love
a
hearing
part of the
that.
process. You're not like an authority figure, just sitting opposite them, dictating to them. And I'm
I have
sure you
some
see.
skills that I have that they may not have, and so do they.
Have you worked with any peers who've actually, folks that you've actually counseled or that you've worked with at to our center, that have actually gone on then to become peers? And there's I know we have like 40 seconds left, so we really can't get into that. But just
I don't train peers anymore. I used to do that to work in the
Yeah.
system because I feel that we're not getting co-supervised as peers. We're
Right.
getting supervised in the medical model, so I stopped doing that. That being said, I'm still doing the work, and if people want to find out, there's an online training
Very
school.
good. Well, Jeff, thank you so much. I could talk to you for hours and hours,
thank
and we'll
you.
have you back
I've
on the
enjoyed
show.
this.
I'm going to shake your hand.
Yeah,
Thank you.
thank you.
And thanks for joining us, and we'll see you next time.